Hearing clinicians and patients share those real-life success stories is inspiring. Thank you, Meg, and congratulations to NAC and its members. So, we've heard how clinics in 3 different states have used SMBP to improve their patients' blood pressure. Now, we will hear about how to integrate SMBP into care processes and workflows. Here to share her insights is Debra McGrath, Director of Health Information Technology at the Health Federation of Philadelphia. Debra, the floor is yours.
Thank you for that introduction, John. I am Debra McGrath. I am the Director of Health Information Technology for Health Federation of Philadelphia. And we're a health center controlled network, and we've been working with about 10 health centers with their SMBP programs. I'm happy to be here today with you to talk about integrating SMBP care processes and workflows as you bring your programs up. So the planning is the key to success here, and today we're going to talk about some key decisions that lead to a successful program in our experience. The first thing that seems to be really important is to identify that priority population. It may feel overwhelming, the number of patients who might be benefit from an SMBP program, but it's useful to think about where you're going to target your resources and to pick a priority population. Some are choosing those patients who are closest to control because they can get them there relatively quickly. Others are looking at patients who are running greater than that 160 systolic. That's a little scary and would like to get them down quickly. And others are looking at those patients who are lost to care. The pandemic has really made an impact on those patients who haven't had a blood pressure reading in the last 6 or 12 months. The next thing that you're going to be thinking about in that in those first key decisions is which cuff. Which cuff are you going to use? We strongly recommend using a validated cuff, which is a little bit beyond the FDA approval of a cuff, so that the results that are coming in from patients is very reliable, and your providers can rely on that information to make clinical changes to the treatment. You also want to pay attention to whether or not there's options for different cuff sizes. As we know, getting an accurate blood pressure also depends on having the right size cuff. So many of the cuffs only come with one size or two size cuffs. We recommend using that wide range cuff size to start, and then look for those cuffs that where you can swap out to an extra large or even an extra small if you need to. The next area to be considering is staffing. Staffing can be one of those things that makes it quite difficult to get a program going. And thinking about those key roles for staffing can be really important. So you need to think about who's going to be enrolling the patient, who's going to be monitoring the patient, how the information is going to be communicated. When you're thinking about enrolling patients into the program, and I strongly recommend that you think about a very standardized and structured enrollment process, we have found that most people are successful when that's done in person. There's a fair amount to teach the patient how to use the cuff, how to connect the cuff through Bluetooth to to the app that's on a phone or a tablet. Getting that initial connection made so that you're actually seeing a blood pressure or two come over, helping them to understand the cadence of blood pressures that you'd like to see happening. And there are recommendations around that. I'll be reviewing some of that in the final slide in this presentation. Some are doing it remotely. Most are, again, that in person and at the time of a visit seems to be the best way to do it. But there's also a lot of success with sending community health workers to the home. That way you're actually seeing the environment in which the patient is taking their blood pressure and can give them good guidance around how to take their blood pressure at home, and how to make sure it's being transmitted. The next step is monitoring when those blood pressures are actually coming in. You need to think about how often you're going to monitor and let the patient know that this isn't a 24/7 monitoring of their blood pressures, but rather looking at their blood pressures in the context of their everyday life and making some decisions that will be communicated with them and made with them about how to improve treatment and get them to that goal of a blood pressure that's closer to the 130/80 range. How long should you monitor? Really depends on how your organization is going to incorporate the guidelines around this. Typically, we're looking at patients being monitored until they reach that control. We are looking for lower blood pressures from home blood pressure readings, so closer to that 130/80 range. And that's really the goal of monitoring, is getting the patient to a point of control and then ultimately graduating them from the program. And there's a lot to be gained from that graduation process, because the patient actually gets a sense of satisfaction out of that. The patient's health is improved, and you've got better engagement from the patient. But thinking that you're going to be watching blood pressures come in for all of these patients on an ongoing basis, sort of forever and forever, is not practical from a staffing perspective, nor does it really meet the goal of the program, which is getting people to the point of control. And again, I'm going to go through a little bit of a treatment workflow at the end that might be useful and helpful. The next area I want to talk about is that of documentation and a communication plan. I just want to be really upfront with all of you that integrating blood pressure values from a home blood pressure monitor into your electronic health record is challenging. And it's challenging for a number of reasons. One is that we are looking at average blood pressure readings typically from a self-monitored blood pressure program. And there really, in many cases in the EHR, there's no place that's labeled average blood pressure. So it makes it a little bit challenging to have that integration happening. I do recommend labeling blood pressure readings as home and averages. And we've been successful using a repository for those home blood pressure readings that then can come into the EHR. And to be perfectly honest, in most cases, that's a manual entry for most of the groups, although we are working towards some integration, and we'll have more to share in the coming months. But using that repository as a place for those blood pressure readings to be validated prior to coming into the EHR is really important, because you don't want there to be inaccurate blood pressures or too many blood pressure readings coming in. That average blood pressure is what we're really going for. Typically, that is 2 readings for 7 days, which gives a total of 14 readings that are averaged. But to be practical about it, getting a patient to do their blood pressure twice a day for 7 days in a row may not be very practical. And what we have found is that at least 3 blood pressure readings on 3 different occasions that are averaged is good. So it's somewhere in that range, and part of the monitoring process ought to be looking for those situations where the patient's taking their blood pressure too frequently or not frequently enough, and hopefully reaching out to them through this process. So how are you measuring success? So the data management and reporting plan is another one of those key decisions. So the first step is to define what metrics you're going to be looking for at the beginning of the program, and to determine how that data will be collected and documented. And we are looking at things like the number of patients enrolled in the program, putting those patients into a cohort and looking at their average systolic at the beginning, and continuing to monitor how average systolic may be improving. Also looking at how many times there's been interaction with a care team member, and how often there's been a change to the treatment plan. You may need to customize or configure your EHR or population health management systems to accommodate this data collection and data reporting. You'll want to think about how you're going to share this data with the care team, patient lists for enrollment purposes, and pre-visit planning opportunities to identify those patients who might be eligible for enrollment or benefit from enrollment. And then regular reporting to demonstrate the progress towards the goal of 80% of our patients with hypertension having a blood pressure less than 140/90. Then finally, how do you use the data to grow the program? As I said, how many patients have been enrolled? How many have reached control? Which patients are we not reaching? So where should we be putting resources? What is impacting control? Are there barriers or challenges around enrolling patients in the program or patients actually using the program that need to be addressed? And then maybe what staffing might improve the program? Thinking about what is the role of various members of the care team. And one member of the care team where we've had a lot of success is using a clinical pharmacist. If you have access to one, they can be super, super helpful as a consultant to the patient, but also as a consultant to the provider team. So this next slide shows you a bit of a workflow, and I'm imagining these slides will be made available to everybody. But this is just an example workflow. Down the left-hand side are the people that are involved, and across are the various processes that are being included, with some sidebar sort of notes about it. So thinking about how this kind of workflow could be developed for your organization really helps you to have it laid out in a graphical representation so you can see where there might be some potential choke points or some opportunities to streamline. I think this having an enrollment checklist can really be helpful. And I have one that I can actually share if that would be helpful to folks. This is the monitoring process. So this helps you to understand what happens once the patient's enrolled and then what happens with those blood pressures, and how you continue the patient in a cadence until such time as they've reached control. And then finally, and this might be a little bit hard to read on this slide, but gives you some ideas about how you can think about a treatment plan and at what point you would make some decisions about either continuing the patient in the program, intensifying therapy, or actually graduating the patient from the program. And again, this will be available. That'll be easier to read, I think, in the slide deck. So that is my discussion about integrating a SMBP program into your processes and your workflow. And I look forward to hearing from anyone who has any questions. Thank you so much.